Kristen Ellis serves as a senior principal consultant with RI International. She is a skilled behavioral health therapist licensed in California and Utah. She possesses an MS in marital and family therapy from Loma Linda University. She has been a service leader with a variety of populations and settings, including crisis walk-in centers, peer-run centers, inpatient and outpatient substance use treatment, and criminal justice settings. Most recently, she was the director of crisis services for RI in Riverside County, using the Crisis Now model and the SAMHSA National Health Guidelines. It is just really an honor to have both of you here. We'll go ahead and fast forward through several slides and get to the main point. If you were here earlier, you know that we're funded by SAMHSA, and we're going to get into, in just a second here, conversation with Kristen and Jamie, hearing about their thoughts on crisis continuum of care services at the intersection of the COVID-19 pandemic and other disasters. So I'll just invite Jamie and Kristen to kind of take it away with this first question. If you would please describe the available crisis services in your county, and well, actually with this one, I think we should start with Kristen, who's been in California. So if you describe those crisis services in your county, or if you're a part of a county contracted service, please describe your services and general information about your county.
Yeah, for sure. So a lot of my experience with RI for the past 6.5 years has been in Riverside County. So that's in way South California, for those of you that aren't aware. And so SAMHSA does recommend 3 main elements for a full crisis continuum, one of which is going to be those call centers. And those are ran by the county themselves using the helpline, which actually is 24/7, has highly trained volunteers. And there's also the National Prevention Suicide Hotline that is answered by D.D. Hirsch in LA County for that region, as well as the Veterans Crisis Line and the Trevor Lifeline for the special populations. The county also has mobile crisis teams, which are their CREST and CBAT teams, which work alongside law enforcement as co-responders, or they're dispatched by 911 currently. And they also have a specialized team called Rocky, which serves children 21 and under during weekdays and normal business hours to support them, their needs, and their families. As far as crisis receiving facilities go, that third factor that SAMHSA guidelines recommend, there are 3 mental health urgent cares, 2 of which that we have ran and helped open since 2015. That's actually where I joined the company in 2015, was through the crisis receiving centers. And those actually offer services in urban and rural communities, because the desert region of Riverside County is pretty rural. It's very spread out. Services are not as available to those in the community, whereas on the west region, it's much more heavily populated and there's things easily available around the corner from you. Other county offerings that they do have are crisis residential treatment centers, which are 14 to 30-day clinical care for somebody who is stepping down from a hold or from a crisis stabilization experience, as well as peer wellness centers, emergency rooms, and then there are psych emergency departments.
So I think if we just kind of lean into that a little bit, SAMHSA is going to go ahead and recommend that you have somebody that you can call in crisis, somebody to come out and see you, and a place to go. It's kind of the vernacular that's really being presented. And Riverside County, fortunately, does have that. Now, if you know how Riverside County is spread out, it's a very long county. I mean, it really goes almost from Arizona to the ocean, a very long county. And it may be difficult in some of those more frontier areas to get in, but I think that Riverside County's done a good job of trying to locate programs across to ensure that you can have somebody to talk to, have somebody to come out and see you, and a place to go. Now, just like every county in California, it's not overwhelming as far as all of the resources that are there. So we talk about D.D. Hirsch as being the National Suicide Prevention Lifeline contact. Absolutely great. The oldest, established in 1958, the largest NSPL in the country. Absolutely love the work that they do, but they're still located in LA County. That's where their office is, and we're talking about Riverside. So as we start thinking about crisis for the rest of the conversation, think about an integrated system that would be on par with like EMS services, where you really need a 988, which is coming call center that can coordinate and do traffic control. I need mobile teams that are able to work street level where people live, work, and play, almost like ambulances would go. And then I need that facility to operate like either an urgent care center or an emergency department where someone can go going through. So Riverside has all of those things in, probably like every county, could use more of it. What's good, you could probably use more of it, and probably a little bit stronger connection or integration between all of those services so it's seamless for the person in crisis. But Riverside overall, I think, does a really good job of at least having access to care.
I really appreciate the context that you set for us, both in terms of the geography of the county and the way that resources are dispersed. I know, Jamie, that you have worked with several different counties in California and across the US at different states, and you're now working internationally as well. I wonder if there's anything that you'd like to add as well from Maricopa County in Arizona, where I know that you have a lot of expertise for that system, please.
So I think if we talk about it from a system approach to Maricopa County, while not perfect, is seen as an exemplar nationwide and probably worldwide as far as how integration of crisis services can go. So I'll just talk a little bit about the numbers. We've got 4.4 million people in Maricopa County. They get about 25,000 calls into our one single point of access, which would be our crisis contact center. Old terminology would be your call center, but since calls are coming in, text and chat and voice, we're calling them contact centers now. So 25,000 times. To put that in comparison, you're getting less than that in LA County in the work that we've done, and they've got over 10 million people. To put that in context, in Georgia, which also has a single point of access, it's got 10 million people in the state, and it gets a little bit less than what Maricopa has. So there's been a big push to get people to call into the crisis call contact center to be able to go ahead and coordinate care. They're then the ones that are doing dispatching of mobile teams. So they're triaging, they're assessing, and if they can't stabilize, they are initiating that next level of care. And those mobile teams are going out 18 to 2,400 times a month. So they're going out 60 plus times a day in Maricopa County to where people live, work, and play, and getting really good results. Between 70 and 80% of the folks that they see, they're able to assess, triage, and allow to remain in community. When they can't, they then come to one of 3 crisis facilities spread evenly around the county to ensure that people can get where they need to, that offers a no wrong door approach, which means 100% of the time they're going to accept somebody that shows up. So you're never in a community, you're never in Maricopa County wondering, where do I go? If you don't know where to go, call a call center or show up in a facility. Every door is open. There is a no wrong door approach in here. So the community has a lot of faith and trust that the behavioral health system will support them, which overall is going to decrease EDs, decrease jails, and decrease law enforcement. And, we could spend 4 hours talking about the benefits for that. So as we talk about a crisis system and in relation to, natural disasters or unnatural disasters that are coming through, I think the culture that I try to push as we're doing consulting, as we're doing work in system redesign, is your crisis system should have a mindset similar to other first responders. We're an essential service. We can't go down. We've got to find solutions. If we can just close up shop because the going gets tough for a month or a month and a half, we're not acting like essential services, and the community will never, ever rely on us for the care that they need. And they will always go back to the other true no wrong doors. Police will always respond. Fire will always respond. EDs will always say yes, and jails will always accept. We want to go ahead and create something alternative to that has that same level of confidence.
I really appreciate that you went straight to the chase there, Jamie, and talking about right now, and that this no wrong door approach, it has to be no wrong door approach all the time, no matter what's happening in the world around us. Yeah. And I wonder if you would both talk a little bit, please, about how your counties have been impacted by COVID-19, wildfires, and other disasters, social justice issues, and or community violence, as it relates to how you're hearing it maybe come up as people are calling these contact centers or showing up in the places along the crisis continuum of care. Kristen?
Yeah, sure. So when COVID started, there was a lot of kind of uncertainty. People were isolating because that's what they were told to do. They didn't know what to do. And so we saw a dramatic, at least in Riverside County, we saw a dramatic decrease in service demand, which when people are stressed, that sounds unusual. But if you're packing together to keep your family safe, it makes a little more sense. And then as folks decided that despair and fear and all those feelings that we all jointly felt set in, then it was a huge increase in service demand at the facilities, because our unsheltered individuals had even less options in the beginning, until Project Room Key did get enacted over in Riverside County for folks to get emergency housing so that way they could have a place to go. As far as how our facilities were running, we had to really increase our PPE. We had to increase the training that our staff knew about PPE, because before you took an annual training on bloodborne pathogens and knew how to don and doff gloves. And then now we have to know how to safely clean and do additional things when folks are potentially COVID positive, but they're also in mental health crisis, and we're prioritizing that piece of it. A lot of the resources in the community had shifted, including some of the mobile crisis teams being more interested in shifting to more of a telehealth method, which then when Jamie and I were talking, is that really a mobile team at that point? And is it a team? Because the team is supposed to be someone to come to you where you work, play, and live. And so those are kind of the things that we saw in the beginning, and the teams slowly went back out into the field. As far as community violence goes, day 2 that we had opened the Riverside facility, December 2nd, 2015, there was a shooting at the IRC in San Bernardino County. And we didn't know what that meant for the facilities. Are facilities in danger of violence being brought to our facility? We also have to prepare for distressed individuals coming and seeking care. And similarly with the murder of George Floyd 2 years ago, there was a huge influx of violence and riots in just the Riverside County area that you had to manage and prepare in case the violence did bring itself to the facilities, and also to how to manage and care for those distressed individuals that were worried about what was happening in their community. COVID also brought loss, and I imagine this is a huge thing for a lot of communities that we've talked to, and all of you, that there's huge workforce shortages. People are choosing to keep themselves and their families safe. Working in a high acuity facility, I'm putting my physical body in danger of potentially getting harmed. But if there's a widespread illness, then I'm potentially bringing that to my family, and bringing them danger. And so there was a huge workforce shortage that COVID brought us. And even now, because folks are realizing what their priorities are, and is this the job I want? What do I really want to do? How much pay am I worth in the role that I'm choosing to work in? I'll let Jamie also talk too.
Yeah, I'll talk about a couple of things, just to kind of piggyback on what Chris and to talk about. And I'm going to talk about COVID because I think COVID has been a significant game changer in most communities. So what we started to see, for those of us working in the field, there was a lot of doom and gloom associated with COVID coming in. We were anticipating a couple of things that probably didn't pass quite like we thought it would. First, we thought there would be a dramatic increase in folks seeking crisis services as the initial pandemic and the lockdown started to happen. We actually didn't see that in most places across the country. RI runs 14 crisis centers, for example, and a couple of them did see spikes where we were over capacity for, a solid month. But what we actually started to see is that initially a lot of folks actually weren't coming in for crisis services. Their potential was the fear of being exposed to other, we would call them guests, but other patients, other folks in crisis, may have overwhelmed actually what they felt their crisis was. So we actually saw a decrease. There were some fortunates for us from an operational side because of the workforce issues that were starting to happen at that point. And then probably 3 to 6 months in, depending on the site, we started to see those increases coming in. We also had actually anticipated increased numbers of depression and suicide as kind of being a second wave coming in. And while we have seen some numbers increase across, it wasn't quite as much of a gloom and doom as we started to anticipate. So what we saw is the county actually impacted, and the way that we provide services start to impact. And there were some opportunities for growth. And I'm going to talk about that, even if that's not exactly what the question is. To lean into what Kristen had kind of talked a little bit about is it was an opportunity for agencies to determine who they were and what they were going to go ahead and do. And we saw a lot, I'm talking a lot across the country. I won't talk specifically about California, but across the country, where crisis providers actually just closed up shop for 3 months.
Yeah.
They said, we're not going out and seeing people in the field for mobile teams. If we can do something with telehealth, we'll go ahead and do that. But they just shut down shop. Either they had staffing issues that they couldn't adjust, or they couldn't adapt their policies and procedures enough to make that happen. Call centers had to make a quick and fast adjustment to actually not working in a call center, but actually starting to work from home and having the technology. So that first month was a rapid adjustment of how we start to do work. What I'm going to then do is I'm going to move into Katrina. We're going to talk a little bit about Hurricane Katrina, because I see some similarities in how response to that particular disaster looked a little bit like COVID. And I'm going to talk about Georgia. When Hurricane Katrina came, Georgia had approximately 13, 14 crisis contact centers across the state. They started to see an influx of people coming in from Katrina, trying to get away from Katrina. How do you coordinate anticipating hundreds of thousands, if not, a million people coming into your state? And they thought, well, we're going to coordinate through our crisis contact centers. These are 24/7. People coming in are going to have behavioral health issues. They're not going to know where to turn to. We're going to go ahead and promote these crisis call centers. We're going to go. The governor actually decided he wanted to have a meeting on a Saturday with the executive directors of all of these call centers. So they started calling all of these call centers, and only 2 picked up. So these are suicide call centers. Only 2 actually picked up. So what they decided at that point is they needed a stronger presence for call centers. They needed a single point of access, and they needed to escalate it to this being an essential service where you can't shut down. You can't close for an hour. If you don't have enough staff, you need your executives to come in and pick up the phone. So what they moved at from that point then is into a single point of contact, the Georgia Crisis and Access Line, for the state of Georgia. And what we're starting to see with COVID is those programs that decided they were not essential services and started to shut down. As rebids started to come out, the states, the counties, the funders, the MCOs all kind of took notice and said, look, this has to be an essential service. I can't shut down paramedics. I can't shut down fire response. I can't say we'll come back in a month. And we really need to lean into those agencies that are going to lean into it with us. So as we started to see, these pandemics coming through, those that really want to do crisis work and understand the need of crisis work are starting to find policies, procedures, the PPEs, the way of doing business to go ahead and meet the needs of the community. And those that were kind of doing it as an adjacent, as kind of part of their other services, really have kind of started moving back into some of the more traditional outpatient types of behavioral health services that you might be able to shut down or convert exclusively to telehealth.
Mm-hmm.
I really appreciate you bringing us back to those early days and talking about the progression. And this is the real life adaptation that is being required of us in these days. And whether it's because of COVID-19 or whether it's because of firestorms or any number of other things that can quickly affect centers and staff to have to readjust, it is absolutely essential. I see in the chat here that we've got a couple of comments. Lisa has talked about it's a huge effort to connect with community agencies, and it's helpful to have memorandum of understanding agencies. She's saying that in Texas. And then we also have comments higher up. Lisa had mentioned increases in 2 high schools with crises, an increase in suicidal attempts and ideation, more fights, more mental illness, but diagnosis and meds. And there's a state mobile phone line, but only 2 hospitals with psychiatrists, psychiatric treatment. And they oftentimes run out of beds. I know this is one of the pieces. Thank you so much for your comments. And Aaron says in San Bernardino County, our mobile crisis responders double as mental health disaster responders with December 2nd attack, fires, earthquakes, COVID response. I wonder on that last point about having to double as kind of crisis responders and disaster responders, if either of you have any additional information that you'd like to share on that idea of like that adaptation in real time.
Yeah. So once again, if we go back to the principal components of a mobile crisis team, and we start to identify crisis, crisis to us is always going to be self-identified. And by that, what I mean is you don't have to convince me that you're in crisis. You think you're in crisis, it's going to be a crisis. I'm not going to put it up against a scale and say, your crisis is not warranting this, that, or the other thing. So in a lot of communities, and I'll talk about Maricopa County, they will go ahead and do disaster response. So traditionally, mobile crisis teams do respond kind of not proactively, but they kind of respond after a crisis has been identified and moving through. But the reality is if your mobile teams are working really well and you are staffed appropriately and you've got the workforce for it, there's a lot of opportunities to support people that are pre-crisis to help them avoid moving in. So I'll give you an example. Maricopa County had, not Maricopa County, actually it was Yavapai County. It was outside our county, which is Prescott, probably about an hour away. We had 19 firefighters die in a wildfire. It was crippling for that community, absolutely crippling. And really, when they did the service, they did a service for all 19 of them. Vice President Biden came out and did the eulogy. They did it in a 10,000 seat kind of stadium. It was massive. And we actually sent probably about 9 mobile teams up to Yavapai County, along with Red Cross, to go ahead and just be walking in the parking lots of that stadium, trying to identify folks. Now, that work is a little bit different. So if I think of a traditional mobile crisis team, I'm thinking of a 75-minute to 90-minute intervention. I'm getting your name. I'm figuring out, what a treatment plan may be, all the things that I'm going to be billing Medi-Cal or an Arizona Medicaid with. But there is a benefit or the opportunity to support somebody, start to assess. And if they are at that level that they actually need that particular type of intervention, we can move it into them. But you've got to be available to kind of start working those fields. Now, Maricopa County has been doing this for years. We've got 22 teams a day that are up and running, maybe 24 depending on the day. So we've got a lot of resources thrown in. I do think it becomes a little bit more difficult in some of your more frontier and rural communities. If you've got one team that's up and I'm going to go support at a rally, or I'm going to go support in a spot that we know, a shelter for people who are displaced because of wildfires, what happens to the rest of my community if my team is taken offline? So all of those things to go into it. But I do think preventive work for mobile teams is absolutely imperative and should be part of the community goal. Once again, don't get reimbursed for it necessarily. And you have to have the workforce to make sure those folks that are truly in crisis aren't then just being diverted over to the emergency departments because there's no mobile teams available.
I'm just holding the grief and the loss as well in these moments, and how you can have complex traumas start to emerge. And the fact that you had people who were walking in the parking lots, that is, I'm really, that's deeply powerful to hear about. I was in El Paso when the mass shooting happened at the Walmart, and spent a lot of time at an entire day at a blood bank. And there was a huge line that went around the building, and people just showed up. And if people couldn't give blood, then they were dropping off crates of water and other food types. And I was very aware being there how different people were reacting. Of course, some people are going to go into some shock, and other people are going to really motivate and activate. And so the fact that you were there, you were literally meeting people where they were at in that moment, is really powerful to be thinking about. I want to talk a little bit. Well, let me stop myself. And Kristen, excuse me earlier, I thought that you were a newbie to RI, but clearly you're not. You have been here for quite a while. And so you've unfortunately probably seen your fair share of different disasters and crises in that region. Is there anything else that you'd like to add on to what Jamie was just sharing before we move?
No, he hit it right on.
So the next question that I might ask you about is how you're seeing community needs changing as these different types of crises and disasters are happening. So you mentioned earlier on that the initial assumptions that you are going to see an increase in calls, you're going to see an increase in people showing up in crisis actually didn't pan out, but then you did start to see a shift. If you could kind of talk a little bit more, because unfortunately, it's not like we're having one mass shooting. These are happening one after another, and these wildfires and so on. So I wonder if you could talk a little bit about how you're seeing community needs shifting of the people who are contacting the crisis continuum of care.
So I'm going to jump in, then I'll let Kristen go ahead and jump in. So what we saw, like I said, with COVID coming in is we actually saw a decrease in people seeking services, but now we are far above baseline would have been before. You know, the SAMHSA at that point was talking about this overwhelming tide that the behavioral health system wasn't going to be able to adapt to. And I think some communities it's going to be that way, and in other communities we've been able to kind of ramp up to go ahead and kind of meet that need. But I almost look at it in a little bit different way. What we've seen, I think, in the last 2 or 3 years has almost been unprecedented as far as it's not one trauma. You know, I've got 35 years as a clinician, and I could say, okay, my community has had a traumatic event this year. Well, I could probably identify in most communities 4 or 5 traumatic events that have happened. We've got COVID, we've got natural disasters, you know, we've got protests, we've got a whole host of issues that are coming in, just one on top of the other. And the cumulative effect of that is much different than maybe what we would see, you know, kind of independently. So as far as the community needs starting to change, you know, everybody, you know, absolutely needs support. You know, crisis for a lot of years there, crisis work has always kind of been identifying, we've got to work with the folks that are currently in crisis. What we're starting to see is the baseline for the folks that we serve is close to crisis. You know, it used to be, oh my gosh, the difference between my baseline and where I am now is huge. But as our communities are coming through, those baselines are moving a little bit more toward crisis. So our services, crisis services, post-crisis, preventative services, all need to strengthen to be able to move through. Another thing that we've started to see from a provider viewpoint, and I'll talk about RI. So RI was a very apolitical organization for years, for the entire time. We don't want to alienate anybody. We're a bunch of clinicians. We love everybody. We're looking to nest and bring everybody in. So we wouldn't have political stances one way or the other. Over the last 2 years, we've decided that if we really want to change the world, we need to step into some of those things. So with the murder of George Floyd, for example, you know, we need to have a response. We need to condemn those sorts of behaviors, even though we work closely with law enforcement as behavioral health partners. But it's really starting a lot of the agencies and a lot of the groups that we're starting to see to take a stand to push back against what is this unrelenting trauma that's coming through our communities. But Kristen, I'll let you jump in as well.
Yeah, I've also kind of to piggyback off what he was saying is our baseline of crisis is so different for the community, but also who we're serving. If I looked back when we opened the Riverside unit in 2015, most of the people we saw were the unsheltered, the people experiencing homelessness, the folks that were released from jail and didn't know where to start on their mental health. That was probably the large majority, with a few folks that had different needs. And now, like, low and no barrier options are what people want. But they're scarce. Having true no wrong door facilities is actually more necessary now, instead of just an elective thing. The folks that I was serving in the crisis facilities was everybody. It's not literally, but it's my neighbor, it's my friend, it's all the people, because all of us, including the folks, all of us that are working, we're all experiencing similar traumas now. Whereas before, the people I served, their traumas, I might be able to understand grief or loss or pain, but we're not experiencing the same traumas. But once COVID and violence and natural disasters and all these things have dramatically increased, we're all experiencing similar traumas, and that's resulting in food shortages, layoffs, increased gas prices in California. And that results in crisis too. People are having less and less ability to care for their family and their self. And so having these low and no barrier options to get a call, to have someone come, to have somewhere to go is a huge, huge shift in the community need versus having these people that are always in crisis and these people that aren't. We all are experiencing that now.
I really appreciate that you would highlight both that this is being experienced by the workforce. We have been doing in another project focus groups with county behavioral health staff across the state. And one county behavioral health executive shared that they have a 70% vacancy rate right now across there. And so it's just, and I just asked in our intro to this conference, how many people were trained in burnout and compassion fatigue as clinicians and they were going through their clinical training or certification process if they are peers? How many work in agencies that have systems in place to undermine compassion fatigue, burnout? And so there are just so many places when we think about the workforce and how we keep the people who are here so that we can make up for that, and bring more people in. But I really appreciate what you're also talking about of taking an intersectional approach to thinking about how we are all living through crisis. And some of us are living through unique experiences with crisis because of racial trauma that is so high right now. And so that would be the people who are accessing our services, but also our workforce. Many of our workforces are not as diverse as the communities that we're serving. And so that I just spoke with a colleague yesterday who just got back from Buffalo and had been doing emergency work with people who had survived the shooting in the grocery store. And she said, she's with Black Emotional Mental Health Collective. And she said one of the people was a survivor from that incident. She said that was the first time she had left her house, 2-3 weeks? She said she's never going to go to the county to access services because there aren't any Black clinicians there. And the reason why she left her house that day was because she knew BEAM was going to be there. Mm-hmm. And so that other side of that diversity, equity, inclusion, I know that RI is really taking a lead in addition to making those statements about the political issues on the community, also thinking critically about the diversity, equity, inclusion of your workforce as well. And that's a really important piece there. I want to note that there are a number of really powerful comments in the chat. So we've got about 10 minutes left. If it's okay with you both, I'd like to maybe invite our participants here to turn on their mics and interact with you directly.
It would be neat if there would be like a program that would just be blanketed across the state and required. We have mental health first aid, and that is required for all of our school districts this year in Texas. So the teachers will be trained in mental health first aid. So I guess that's a start.
Thank you so much for that, Lisa. I'm going to go to Jamie and say, Jamie, if you had a magic wand, I would love, to get you into a position where you could just move resources around. How would you do it from a systemic approach? Kind of speaking to what Lisa was just talking about, seeing that there is this need in the workforce right now. What would you recommend?
Well, I'm going to talk about a couple of different ways to go in, some realistic, some unrealistic. For me, as a consultant, what I can tell you, at some point, if you give me enough resources, I can solve any problem you've got, pure and simple. So when we start talking about things like compassion fatigue and burnout and those that come in, there's various reasons for that. But generally what it is we are understaffed. And we tend to have higher accountability for the work that we're doing than a lot of other professions like banking, for example. So if we take the role of teachers, for example, I do think additional training is great. Mental health first aid, absolutely great. There's a lot of trainings out there. But when we ask our teachers to be a safety net for their schools, for their students, and we don't give them other options to escalate it when it is beyond what they can do in their 8 hours in the classroom, we're basically giving them accountability for helping somebody, which all of us are looking to help, without the resource to actually make it happen. And that's what leads to burnout. So if we can train, but if we can create a system in place that you say, I can move up to my level of competence. And as a teacher, behavioral health, long-term resident, all of those things are a little bit out of your wheelhouse. For a clinician, 30% of the folks I work with, I'm going to refer to Kristen and her inpatient programs, right? If I don't have that, I'm increasing that. The second thing that we need to focus on then a little bit is caseload. So what I can tell you is I was in private practice. I was working with the walking well in private practice. If I saw more than 5 people in a day, I was starting to get crispy. I was starting to get toasty. And these weren't people that I was concerned were going to hurt themselves after they left my office. But yet, if we ask our crisis providers to see 6, 7, 8 people a day, if we ask our case managers that are working with a higher acuity population to work with 30 or 40 people as opposed to 15 and work with them really well, those are the issues that tend to come in. So once again, I think the funding aspect needs to be strengthened. From that, which means that we need to make sure everything that we do gets Medicaid or Medi-Cal billed. We need to advocate for the right rates at the state levels. And we need to advocate at the federal levels to go ahead and create certain types of provider types that come in. Now, what I will say is I think the saving grace in the U.S. coming forward from a workforce viewpoint to extend the workforce is peers. I love peers for a variety of reasons, but one is they are extenders of the workforce. So if we talk about a mobile team, if I'm going out by myself to assess somebody in community and I see 5 people, I'm a little anxious. I'm a little bit stressed. I have no one to process with. I am going to burn out in 6 months. But if I've got a partner, I now can probably manage and carry that load a little bit longer. The thing I like about peers is that they extend the workforce. But also when we start talking about equity and diversity and inclusion, I can tell you from an operations viewpoint, it might not be politically incorrect. I would love to have my professional staff look more like the folks that we serve, but I can't make resumes appear. If I've got one opening and I only have 2 applicants for that, I don't have a plethora of options to choose to mix and match, but I can with my peers because we can start to create peers coming through. So RI, as an example, over 50% of our workforce doing direct services are going to be persons of color. But what I will say is that probably more in our peer workforce, which is 50% of the staff that we have, versus our professional staff, just because we have more limited options. And if I am stealing professionals, if I'm bringing a professional staff in, I've probably stolen them from somebody else who now is decreasing those numbers as well. But I do think it does come back to funding. So if we look at behavioral health, and everybody here work in behavioral health, we've always been less than physical health. You take a look at, my wife got an appendicitis. She was in a hospital 26 hours, got a $36,000 bill. Well, if somebody's with Kristen for, 36 or 26 hours, they're probably getting a $700 bill, but probably a lot more TLC during that time. So we've always been kind of funded, I'm going to say inappropriately. But what we also do know is that if we can go ahead and provide the right behavioral health and crisis care, we actually decrease overall physical health spends as well. So there's a lot of interrelation. I think we've done a poor job of advocating. But once the reimbursement starts to get commensurate, I can increase my workforce. It can be I'm more likely to get people wanting to come into these high acuity types of jobs. I can stretch my peer workforce out. I can give them the training they need. I can ensure people have the time off, so I'm not calling them in on Saturdays if that's their day off because somebody didn't show. And I think we're going to start working through that. But what I can tell you, when I was in private practice, I was the worst at getting paid for it. If someone says I don't have insurance and I can only afford $5, I'm going to see you for $5. So if I'm willing to say that, it's tough to get the state to say, you need to pay me $85 for that visit if I'm willing to do it for $5. So I think it is a little bit change in the mindset of how we do with a focus on the money, because no money, no mission. and getting, once again, equal billing and parity with physical health.
We're seeing more and more research that's showing how directly connected they are. And so, of course, if you're living with depression or anxiety, you're going to have a higher rate of cardiovascular illness risk of later on. But even if we get really more myopic and focus on COVID-19 and people who are surviving hospitalizations and the trauma that is a part of getting through an ICU stay for many people, not to mention even the long-term COVID long haulers who are experiencing inflammation of the brain. We are seeing many different places where it's so immediately connected. So it's an interesting point that you bring up, Jamie, to think about our funding and also how we might be making the best use of what is kind of a little bit of a watershed moment from the feds and at the state level. There is new money that's coming forward right now. And so how do we harness that in the best ways possible? I'm aware we've got 2 minutes left. I want to stop though, and just see, Kristen, if there's anything else that you'd like to add in here at this moment.
I mean, I think I touched on it earlier, but it's really, really important that we as behavioral health providers and those of us that work in crisis care have to really embrace that this is what we do. Like, nobody's too sick or too broken for the emergency department, and nobody is too escalated for a police responder. And so crisis is crisis. And I mean, I'll admit, when I started in crisis, I had to learn that too. But who's our priority right now? Is it our community? Is it the agency? And when you have no risks to the agency, you have huge high risks in your community. And I've seen the best successes in our programs when we are no wrong door, literally no wrong door. And the person that's in front of me, they're defining their crisis and I'm working with them along their way.
Wow, you are cut from the same cloth of the other people that I've met at RI now. I mean, that was absolutely brilliant response in the idea of taking risks at an agency level, because that is the best equation for the community. And Riverside is so fortunate to have you there. My gosh. It's really a telling thing that you would even put it at that kind of a perspective. And I know, Jamie, you've oftentimes also talked about peers being the first in and the last out in moments of crisis. And so there's something really unique that peers can bring in moments of crisis, developing trust and rapport that just can't be, other people who don't have that lived experience.
It really can't be paralleled. Like, having the peer be the first and last person that you see when you're in crisis is so powerful, because you get a lot less of that white coat syndrome. You get a lot less fear, and you get a lot more buy-in from the people that are in crisis and probably already not trusting of a system.
Well, in crisis, you take a look across the lifespan. How many times have you been in crisis? And if you're going and talking to somebody and they pathologize it, oh, you're in crisis, there's something wrong with you. No, I think crisis is a natural state. Grief is a natural state. If you never had grief, I would think that would be more the pathology. And when you start to incorporate peers in, what you're saying is we're removing it from the pathology and we're looking at what happened to you as opposed to what is wrong with you. It's a very welcoming environment to work in that. And it also gets you where you need to get to, because I'm not operating from a less than or stronger than kind of position. It's how can we help and how can we be a support? So I'm always going to talk about the benefits of peers in crisis work. It works on so many different levels.
I am so appreciative that you would end with that comment. And it's what I've seen with the peer workforce at RI and many other places as well, is that there's a sense of hope that you can get from hearing another person's story from recovery that you cannot get in any other way. Thank you all so much for being here. Thank you to everyone who's in the audience.